cortex. Up to 25 contain calcification, and adjacent bone show hyperosteosis.
معلش يا نور ممكن تشاوري؟
On MRI, here in T1 iso-intense lesion, and in T2 also iso-intense lesion with a small cleft of CSF. On post-contrast, it has a homogeneous enhancement with a dural tail. %50 of cases demonstrate adjacent edema, and they almost always shows strong homogeneous enhancement. And up to 72% of cases shows dural tail. This dural tail is due to reactive thickening and enhancement of dura. This is useful to differentiate cerebellopontine meningiomas from schwannomas, which do not typically have a dural tail. On MRS, meningiomas demonstrating high choline to creatine ratio, low N-acetyl aspartate peak, high choline and alanine peaks. Their alanine to creatine ratio is useful to differentiate them from other intracranial tumor. Atypical meningioma or grade 3, higher grade meningioma, usually located in the calvarum rather than the skull base, commonly invade overlying bone and skull. They have little or no calcification. In this case, atypical meningioma showing heterogeneous enhancement, mass with dural base and CSF clefts and bone involvement. The cortical interface is less distinct when compared with the typical meningioma. There is a moderate amount of vasogenic edema and show internal calcification. Grade 3 or malignant meningioma display features of aggressive disease with complete loss of CSF clefts, no demarcation between tumor and brain parenchyma, and it invades the surrounding structure. Metastases are very rare, but most arises in the lung. In this case, there is a heterogeneous enhancing mass with a wide dural base, a dural tail, and the cortical interface is poorly outlined, suggestive invasion of underlying brain parenchyma and adjacent skull. On T2, the mass has a surrounded by vasogenic edema and midline shifts. Diffusion weighted shows heterogeneous area of restricted diffusion extended to the adjacent cortex. One of the differential diagnoses of meningioma is dural metastasis, most originated from breast cancer, prostate cancer, and lung cancer. Dural metastases are frequently solitary, leading to misdiagnosis of meningioma and delay in care. They appear as focal nodular thickening or diffuse as smooth thickening following the contour of the calvarum. They can be associated with vasogenic edema. Strongly enhanced lesion may cause local invasion with destruction of the bone. On MRS, show low NAA to creatine ratio and high lipid to creatine ratio. In this case, the post-contrast CT showing strongly enhanced extraaxial lesion with a wide dural base and associated with vasogenic edema. There's no bony hyperosteosis or erosion. The same lesion has indistinct cortical surface on T2, and post-contrast MRI shows slight heterogeneous but strongly enhanced lesion. On diffusion weighted demonstrates intermediate restricted diffusion within the lesion. Another differential diagnosis, solitary fibrous tumor of dura, is a rare dural neoplasm, more commonly occur in the musculoskeletal system and the skin. but may affect central nervous system. Show no calcification, destruction of wound rather than hyperosteosis. In this case, the image show extra-axial lesion superimpose the falcus cerebri and enhancing tail anteriorly. On a flare, the lesion has high and low signal. These low signals are enhanced with contrast. On CT, the mass is hyper dense with no area of calcification. A primary dural lymphoma, CNS lymphoma, is classified as a primary when diagnosed in absence of systemic disease, or secondary as an extranodal feature of systemic lymphoma. Common location include falcus cerebri, tentorium cerebelli, and paracellular region. The lesions show more vasogenic edema than meningiomas. Up to 50% of patients have more than one mass. In this case, showing multifocal dural masses and diffuse enhanced thickening of dura. In ADC, showing intense restricted diffusion within the multiple dural mass. Melanocytic neoplasm or melanocytoma. Melanocytes are normal cells found within the leptomeninges, mostly around the base of the brain stem, and the anterior cervical cord. 90% of metastatic melanocytoma is cutaneous in origin. On CT, melanocytoma appear as isodense or hyperdense to cortex and strongly enhanced in contrast to meningiomas. They rarely demonstrate calcification or hyperosteosis. In this case, the non-contrast CT show hyperdense extra-axial mass causing mass effect, and on the right temporal loop, and showing an hyper-intense in T1 and T2 with a mild degree of edema. Post-contrast show enhancement in majority of the lesion, with a dural tail anterior and posterior to the lesion. Gliosarcoma are a rare primary glial tumor. Two types of radiological appearance are seen in gliosarcoma. Deep parenchymal lesion often have an ependymal attachment, or peripherally located lesion that is solitary and associated with a dural attachment. In this case, the post-contrast show vascular and heterogeneously enhanced lesion with the necrosis and hemorrhage inside the mass. In T2, showing CSF cleft and periregional edema. Selective right internal carotid artery angiogram demonstrates a high vascular mass with multiple abnormal and aneurysmal vessels. Tuberculosis, one of the granulomatous disease. TB of CNS occur in around 1% of all extrapulmonary TB. They establish rich foci in the meninges and subependymal region. This foci rupture into the subarachnoid space and other intracranial compartments, resulting in suppurative basal meningitis, cerebritis, or abscess formation. Parenchymal tuberculoma also directly involve the meninges or rupture to cause pachymeningitis or leptomeningitis. Meningitis affect mainly the basal meninges. No calcification in acute phase, erosion of bone instead of hyperosteosis. Peripheral parenchymal lesion may have ring enhancement rather than solid. In this case, contrast enhanced MRI showing enhancing basal meninges with parenchymal tuberculoma. Sarcoidosis, another granulomatous disease, is a systemic disease of unknown origin characterized by formation of non-caseating granulomas. Dural involvement may be diffuse, thickening, or focal mass, which tend to be isointense on T1 and hypointense in T2. Post-contrast show homogeneous enhancement lesion. The low signal intensity of T2 is thought to be secondary to accumulation of fibrocollagenous material. In this case, MRI show a Blake-like hypointense lesion involving the frontal dura. In post-contrast enhancement, leptomeningeal involvement with extension into the sulci is seen in the right side. And in this case, the post-contrast MRI show a nodular enhancing leptomeningeal lesion involving basal cistern and leptomeninges. Okay, thank you.